Selalu tu pada dia susah kerja.
Okay. Can you see picture A and B?
Yes, I can see. A is.
Can you name the instrument A and B?
A is the card for set. B is the
Full name? No.
For A. I don't remember. It's a cutting for set.
Okay.
B is the
Is it really? Take your time.
it's not cutting for set. It is used usually in the functional design surgery where we want to trap soft tissue.
Can you name the instrument B? Instrument B?
B is
You're not sure.
I know this human
Tak sangka. Okay, so
Too simple.
Too simple.
Kenapa dia tak sangka tak? Saya tak ada instrument ni, saya gambar je lah. So do you know what's the difference?
The difference is A is a cutting forceps, so you can use this to take biopsy to cut the soft tissue. Whereas for B, you cannot cut. You don't use it to cut the tissue, but you can use it to pull or to detach the structure, a soft tissue from its attachment. Indication for both instruments we can use during functional endoscopy science surgery. For example, for instrument B, when we want to use it to remove polyp, for example, from its attachment. For A, it has the one side is open, the other side is not. It's closed, so it can cut the tissue. So you can use it to take biopsy.
We'll go to the next question. Is it okay?
So that's a cutting forceps, is it? This one?
A.
Is it this one? Cutting forceps. And this one?
That one is
You said tissue forceps just now. Bexley, right?
Bexley,
right?
Bexley.
Oh, that that sudden revelation. So you said it's a soft tissue cutting forceps, is it? Just now. Yeah, actually, cutting forceps is actually meant for bone. Actually, it's when we cut together with soft tissue with the mucosa. But when it is defined, it's defined as cutting bone. This one is actually for soft tissue.
Soft tissue.
Yes, but when we
Soft
cut,
tissue kita yang tak tajam lah kot.
normally
Tapi
because
sepatutnya
soft tissue, because you hold it and then you twist it like what I always say crocodile, but don't mention during exam. Crocodile punya twist, right? You twist it, it come off. But you will not do that if you do it for bone. It's not going to come off, so you need to cut it. But the way that you define is like soft tissues, right? Which is actually not really true. So you have to be sure that when you use this, it's actually for more than mucosa. This is soft tissue. This is actually for hard tissue. And this is the vibe that you get, you know. Don't think that it's easy. I'm not supposed to learn this. This is exact question actually. This is soalan bocor ni. Exact question that you're going to get, and surprisingly, majority cannot answer. We're quite shocked. Kita bagi local tu pun tak nak jawab. Bagi ni pun tak nak jawab. And then you say, I think probably you guys read all the difficult one probably. The easy one you don't concentrate so much.
Because I think Dr. Ramzan si bagi banyak disease dah, banyak bagi tadi. Jadi I bagi berapa instrumen lah warming up question yang dia akan selit-selit dengan ada question pun boleh. Next question. Can you see this clearly?
Yes, I can see the picture
So
clearly.
what is the instrument set? This is an instrument set. What do you think the instrument set should be used for?
For nasal reduction, nasal fracture reduction.
Are you sure? Oh, tak jelaskan.
Okay, wash.
You think this is pressure
No,
wash?
okay, sorry. is used for septoplasty.
Okay. Can you tell me can you go through the steps of the septoplasty?
Septoplasty is a surgical procedure to correct the septal deviation. This is done under general anesthesia, and this well-informed and consented patient lying in reverse triangle position. I start the procedure with nasopacking to reduce nasal congestion by using Morphet solution, and then I will give a local adrenaline, marking adrenaline, pre-working plus adrenaline at the septal mucosa. And then I do incision and clear septal area. We have two kinds of incision, Killian and also hem transfixation, depending on the dislocation or septal deviation. Usually, Killian incision is 1 centimeter behind the mucoperineal junction. Then I will raise the mucoperichondrial flap as part of the superior tunnel, and also inferior tunnel is when I raise the mucoperi-osteal layer. Then I will separate this flap from the cartilage, and I will connect both tunnel to make a one common flap. And then after that, I will make incision through the cartilage to the other side, and then separate it from the contralateral mucosa. And then I remove the deviated part of the septum using I will cut it using cartilage scissor, and I remove it. After removal of the deviated part of the septum, I will reposition the flap, and I can suture the initial incision, the Killian incision, or I can use elastic sheet to prevent septal hematoma in that area. Usually, I don't do nasopacking post septoplasty, but depend if bleeding is well controlled, then I don't do packing.
Regarding the incision for the septoplasty, how do you choose the incision position?
We have two kinds of incision, hem transfixation, which is at the
Which sites? How do you choose the sites?
Theoretically, we do the incision on the concave side, but it depends on surgeon preference. For myself, with my limited experience, since I'm right-handed, I prefer to do incision on the left side of patient septum. I find it quite easier for me to raise. Some surgeons prefer to do on the convex side. But
reason why
theoretically,
concave, why convex?
reason it says that if you raise the layer, the flap on the convexity side, it can prevent septal perforation.
Just to prevent tears.
Test.
Because you go concave, it's less chances for tearing to happen. But you go to convex, because you have septal spur, we always see this, right? You always will tear anything open.
Got tension.
Because of the build up or the structures that is surrounding that area. That doesn't mean that it's going to be no tear at all, but less chances, I suppose, right? But then again, that is in theory, but somehow or other we always, no matter what, goes to the convex side, right? I think that's a nice way of you to answer that question, but we have to be clear when you do, when you mention about the incision, whether that is SMR or septoplasty. Isn't it? You mentioned Killian. Killian is not for septoplasty. Killian is for SMR actually. So we have to be clear. But again, that's theory. In reality, we are doing septoplasty, but we are doing SMR actually. Isn't it? SMR is for what actually? Right? When you do SMR.
It's quite radical procedure to remove this septum. Usually done in late outpatient. It's for severe septal deviation.
Again, sorry, what is SMR?
SMR is submucosal resection. part of the nasal septum by leaving the L strut, the dorsal and caudal strut, about 1 centimeter. We remove the septal cartilage, perpendicular of etamol and maximum recurrence. Generally, it's a more radical removal. Nowadays, that we don't see much of this now because with the endoscopic advancement, we manage to do correction, targeted correction at the deviated part of the septum. So for SMR, indication
What is septoplasty then?
septoplasty is a form of septal correction of septal cartilage in which we remove part of the cartilage, especially at the deviated part, and we do correction by replacing back the cartilage to make it more straighter. But in practice, I don't see the true septoplasty done.
Everybody agree with that. That's how it's been defined actually. But in reality, we do septoplasty, but actually we are doing SMR. That's how it is being defined. When you do septoplasty is reconstruction. Like you do septorhinoplasty, you remove, you put it back. You remove, you put it back. Isn't it? Rhinoplasty, you refashion it and whatnot. That's how normally when you are what you're supposed to do for septoplasty, recon, right? But we don't do recon actually. We are doing SMR. Most of the time we do SMR, but it just labeled as septoplasty, isn't it? Is that be done any other way or techniques in other hospital that you've been to? Everybody does the same thing, right?
Yes.
They put septoplasty, but they do SMR, isn't it?
Yeah.
That's what you are doing also. I think most of us are doing that. So, but at least you have that kind of definition in your mind. When you do septoplasty, that's what you're supposed to do, reconstruction. I mean, you take out the cartilage, you put it back. You straighten it by scoring, you put it back. That is septoplasty. But when you remove, you reset, it becomes SMR. And how people have defined previously, because previously, they do without endoscope. So that's why the how they put it incision a little bit posterior when do SMR, because SMR is supposed to target both cartilage and bone is towards the back. So then when you use a headline, it's not going to be easy to place an incision and then to reach further posterior. Whereas as compared to septoplasty, which is more anterior, so the incision is more placed more anteriorly. That is actually meant for all this kind of non-endoscopic like kind of method. You use a headlight and also use a speculum to reach deep inside. But nowadays we are using endoscope, and endoscope is not that difficult to go in posteriorly. So even though we do septoplasty, we can go even more posterior wherever you place the incision. But at least you know what is an SMR and incision for SMR, and what is SMR is all about, and septoplasty what is meant to address. Right? So we are clear on that. Thank you. Sorry for interruption, because I think that's important.
Complication. Complication of septoplasty can be divided into intraoperative and post-op. For intraoperatively, complications are bleeding from mucosa, septal perforation, injury to surrounding structures such as inflated veins and so forth. For post-op complication, patient might have infection, septal perforation, septal hematoma, and nasal blockage.
So septal perforation tu, septal perforation tu where does it happen actually?
It happened along the way during elevation of the mucosal flap.
How does it happen?
It happened because of inappropriate technique of elevating the mucosa. It also happened because of the abnormality of the septum itself, such as if it has septal spur, where the convexity or the elevation is too much at the degree of very acute injury, so we have difficulty to raise the flap at that ankle area.
When
Septal spur and the maxillary crest.
If there's no septal spur,
If there's no septal spur, yes, we
But-
still can create the septal perforation at the most elevated part of the back.
Oh, that's almost like septal spur. Okay, I get it. I get that point. But where else?
Where else?
If there's no septal spur, there's no very like a very sharp septal deviation.
during incision, during the first incision where we actually puncture the other side of the mucosa.
It actually can happen anywhere along the, as long as the mucosa on both sides tu same actually same location. Apa nak cakap? Faham tak? Kalau you buat on the right side pertama anteriorly, and then on the when you go to the other side with the other flaps, you go through and through the mucosa from both sides. Or the perforation from right side and side ni mucosa sides dia sama.
But you must understand when you keep there's mostly at the junction of cartilage and bone. That's how it is being described. When you actually elevate the mucosa of bone and cartilage, where the junction is where it is very tightly adherent. That's how it is being described, tightly adherent. So when you elevate off the junction between bone and cartilage, right, the mucosa goes inside that, right? So you need to elevate that more, probably slowly, more carefully, because you create a tear there, and then you're not careful, then you go to the opposite side, right, tearing both sides, then that's where septal perforation will occur. Right, that's precisely where it's going to happen. Probably you don't appreciate that because you don't know, right? But now I hope you understand, you appreciate that.
Last question kan?
Thank you.
Habiskan je. Last
Habiskan.
question.
Okay. This is our instrument. It's
Name the
called
instrument?
This is a power instrument. Which is called micro divider. Indication for this is one is for functional endoscopic sinus surgery. Second for inferior turbinate reduction. Third, it can also be used in inverted papilloma or fungal sinusitis. Fourth, can be used also to debride hypertrophy, adrenal hypertrophy.
Okay, can you tell me how do you actually use it, operate it?
This is power instrument. It has a specific speed. For micro divider, the speed, the range of speed is about 5,000 to 7,000 RPM. How to use it intraoperatively? A surgeon need to visualize that.
Precaution and
Precaution to prevent injury to the surrounding area. You need to see the divider blade. It should face towards where we want to do the resection. But most importantly, you need to see it to prevent injury.
How do you prevent injury when you use a micro divider?
First, when we insert the instrument, we need to keep it close. You don't see the hole at the end there, but when you use it, there's a pedal. You can press to make it open before you switch it on to debride the soft tissue.
you suck it, right? You suck
Yes,
it.
we start soft tissue to bring it into the hole there.
What are the possible complications when using it? Let's say you're doing fast.
Complication. One of the complications is injury to the vessel. So when you simply debride
What vessel?
a vessel for fast, we will encounter the important one is interior complications.
Okay, apa kita dengar? Ada complication.
Um, Also, another complication is during fast injury to lamina papyracea.
Carry on.
Carry on. Injury of the lamina papyracea by using divided to lateral, it can cause failure of the fat coming out from the area. But sorry, I'll start. I tak tahu dah cakap apa.
Dia extraocular muscle kan.
So basically injury to vessel, injury to lamina papyracea, to periorbital muscles.
Bukan injury to lamina papyracea. Injury tu apa benda yang takut? Intraorbital complication. You hit extraocular muscle, dia dapat deportation, dapat diplopia kan. Bila you breach the lamina papyracea lah, akan ada densin medial orbital wall. Tapi kalau ke belakang, you hit the optic nerve sebab effects tu dekat maybe
So basically, I can mention complications of fast intraoperatively. Kan?
sebab examiner ni tanya for example in test.
When using, I'll start when using this actually. But yeah.
Nak lagi daripada bawah pula.
Okay.
Okay.
When you actually, which area specifically that you think most likely you're going to have this problem? When you do it fast, you said you're going to, cause injury at the lamina papyracea. Yes. Which area?
First, when we do asymptomy, there's a risk of injury to the lamina papyracea as well because of its attachment. There must be careful while doing that. Secondly, injury during
So yeah, so asymptomy and then.
next step would be idiomyotic atrostomy, but and then followed by enterectomy. During enterectomy, we start by uncapping the infromedially to avoid complications.
This sort of presentation during exam, for sure you come back fail. For sure you go back fail. Because I can see that your practical knowledge is actually very minimal. You have some theory there, you know that using microdivider can cause lamina papyracea. But I also want to know where specifically you're going to cause this damage. And that is when you do anterior hemodectomy, posterior hemodectomy, especially posterior hemodectomy. That's why most likely you're going to cause a lot of problem when you do dissection. And this you can only get when you do cases, when you go in, you do yourself. Because when you do yourself, you get more adrenaline rush, right? You get scared. You assist, you don't get scared because surgeon is doing, right? The surgeon doing complication, you handle yourself, right? The surgeon have to face themselves. But when you do, you get scared, right? Because this is where I should be careful when you are doing hemodectomy, where you're going to come across the lamina papyracea most of the time. When you do asymptomy, there won't be any much of a damage around that, unless you are really that very heavy-handed to pull on the superior attachment. then you're going to come across the lamina papilla, but you don't get that injury over there. You get that injury when you use a microdivider and the enteroembolectomy, because if you're not careful, you use the microdivider, you're going to go across the lateral wall of the nose where the lamina papilla is there. All the area is lamina papilla all the way back. All when you do enteroembolectomy is lamina papilla area already, right? You open up lamina, enteroembolectomy is lamina papilla is there already. Is your lateral boundary is lamina papilla all the way back. You just don't realize it. All the way back is lamina papilla, enteroembolectomy. You go posterior embolectomy is lamina papilla away until the back there, where you can even come across the optic nerve, right? And that is where the fat is very minimal at the posterior emboidal region. Very minimal. You reach that extraocular muscle already. Then you're going to get squeezed, because medial rectus is there, and with the microdivider, easily you entangle the medial rectus. That means cut already. And then some will also cut optic nerve. Not even extraocular. Optic nerve also can cut with the microdivider. And if you're not careful, you don't look at the CT scan properly, you don't realize there is dehiscent. There is no lamina papilla. You scan lamina papilla, there's none there. Then you cut, there's something there being sucked in. That sucked in is actually periorbital fat, because there's no lamina papilla. And you put in a microdivider, and this is one question that has been asked during Viva. Can you cause damage to the eye or orbit without breaching lamina papilla? Yes, you can, because the suction is very strong with this microdivider. You put it there, there is dehiscent, is going to suck in the periorbital fat without you realizing. And you thought, oh, polyps come in inside the suction. No worry, because I have not breached the lamina papilla. And lo and behold, sometimes it's there already. They keep on cutting. You're going to cut the muscle, you're going to cut the optic nerve. So, right, this sort of performance is very dangerous, because I can see you don't appreciate much about doing the procedure. We want to see you have hands-on experience, because examiner want to see after we pass you go out, you can practice yourself. If you cannot appreciate where you're going to cause the damage, then they won't have confidence with you, right? So please be careful. Please appreciate when you ask simple things. Actually, simple things like this will kill you. I can tell you that. If I ask you robotic surgery in FAST, you can answer I'm okay with it. But you cannot answer how you going to create complication during FAST. There's no forgiveness. It's straight away fail. Simple as that. Okay. Cukup dah?
Okay lah. Dia saja cukup lah.
Cukup dah.
Okay.
Okay, overall, you're quite good. But I think there's a concern there about FAST, because nowadays I think a lot of examiners are very concerned about FAST. Because I think there's a lot of problem with FAST in our practice nowadays. So please pay careful, more attention on the steps and complication of FAST. And also the practical issues, that hands-on, what you have done during your residency program, 4 years. That means when you go in, do FAST, what you anticipate that you're going to have problem with, right? When you go to spinal area, what are the problems and things that you must be doing, what you should avoid, this all what we have discussed probably during, when we are in OT together. If we don't ask, you should ask the surgeon, right? This is what sort of thing that we expect from you actually. Practical, because sometimes you give textbook answer. We don't want that textbook answer. Everybody may know, perhaps, probably. But when the practical issues, this is what I actually want you to, be more careful with. We ask you straight away. You can tell that means you are very, exposed already. And ask you about anterior artery is not of course you can probably come across that when you remove the anterior cell, but most of the time it's frontal recess. Frontal recess is going to come across anterior whether you like it or not. Right? Frontal recess. Okay.
Thank you.
Ada?
Habisnya soalan saya. Saya tak 30 minit saya sempat cari instrumen je.
Oh, dah, itu dah saya bagi time saya tak apa. Saya bagi Johnny. Ada lagi soalan? Tak ada dah. That's all.
Sekejap saya
So far, what have you done this morning? What have you
banyak
done?
soalan memang.
Oh, dah dapat dah soalan bocor semua. Ni boleh saya lapor?
Boleh.
Ni siapa yang ajar?
Template tentasi je.
Jadi dah, dia kata apa ni? Cerita apa ni?
Template untuk long speech.
We have gone through all this before, right? Yeah, lagi. Never enough. Every Monday morning, what? Takkan tak tahu lagi ni. You know this already. You know, exam being exam, let's go to the direct to the point. Don't be around the bush. Direct to the point. You know CRS, you need to know, right? CRS. You need to know about all this CRS ni yang fungal sinusitis. Fungal sinusitis. Okay. You need to know about unilateral mass. And when we talk about this, there should be GNA should be there, inverted papilloma should be there. Ini memang favorite lah. Wherever you go, UM, UKM, this is the favorite question. For sure. And then the sinonasal malignancy. These all the SEC area lah. SEC, orbit involved, not involved, and probably you're going to come across olfactory neuroblastoma. Sometimes when you are very lucky, you get lymphoma in the orbit. Lymphoma in the orbit. Sorry for my poor handwriting. Lymphoma of the orbit. This came during the UKM. I think UKM exam. Who was that? Did you manage to get this case? UKM or UM? Lymphoma of the orbit. Patient came with UKM, right? Lymphoma of the orbit. Patient came with epistaxis. Unilateral. The changes hardly very minimum in the nose, but mostly in the eye. Lymphoma of the orbit. Oh, very difficult case. That's why I said you're very lucky. So it's quite simple. So when it is simple, it's as simple as this. You cannot struggle. You must answer very well. We expect that from you, especially CRS. Right? Patient come in, you know already. You must ask nasal block, nasal discharge, headache, facial pain, smell. That one, TikTok, must ask. No question about it, must ask. No ambiguity. Right? Sometimes you present it on CRS. You don't talk about smell. This is long case. And when patient with CRS, you suspect CRS, talk about nasal block. The severity, how patient present, the development, the discharge, thick, scanty, blah 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 blah, false smelling, thick, greenish, yellowish, all that must come up like non-stop, like very fast flowing faucet water, pipe water. Tak ada macam Kelantan water dribbling. We don't want that because this is a common cases that you see. And these are the common cases that you're going to handle. And you must know. No apology. No, cannot say, oh, I'm very sorry, I'm not in the mood to talk about CRS. Cannot. Must know. You don't know, you fail. Habis. Full stop. You don't know, you fail. Right? And then when you discussing CRS, sometimes there are some findings that may actually leads to the diagnosis of fungal sinusitis. Now you must talk about fungal sinusitis. And fungal sinusitis, whether you like it or not, you must know also. Even though sometimes it's not that, it's not that common actually, but being in tertiary hospital, you tend to come more often across this kind of cases, betul tak? Right or not? Actually, it's not common, but because we are handling a lot of these complicated cases being referred to us, then we come across this fungal sinusitis. But this also the sort of cases that you're going to come across during exam, whether it's in long case, whether it's viva, and viva is very, very common and quite popular. In fact, during last exam also we asked about this fungus, where there were this endoscopic picture, right? We show a picture endoscopic, this middle turbinate, right? This inferior turbinate, middle turbinate, inferior turbinate. There was this casting there, blackish discoloration, right? Blackish discoloration. And you describe blackish discoloration, then you must give your division diagnosis. Alright? And one of it must be fungal sinusitis. Alright? But sometimes, I don't know, during exam, some people cannot describe. Some people cannot give the diagnosis of fungal sinusitis. You know already, blackish discoloration in the nose, you must be thinking about fungal sinusitis. What else is that? Right? All those, tumors, we only cause bleeding, right? We cause bleeding, blood clotting, blood clot. You may see blood clot, but they won't cause blackish discoloration. Only fungal sinusitis will cause blackish discoloration. So, if you describe there is a discoloration and whatnot, you must think about fungal sinusitis. And in fact, it is fungal sinusitis. And any unilaterality, you must think about tumors. Whether it's benign, you start off with benign and then you go to malignancy. Superior, don't forget, olfactory neuroblastoma, right? Is superior. I just put GNA here, but clinically, you clinical short case, long case, you won't get GNA because of bleeding. But viva may come in, right? And then the other thing is, don't forget about mucosil. What? Mucosil. Yes. Don't forget. Even viva also may come across that. You may get some pictures being shown. What is this? Right? Frontal bulging like that. Think about mucosil. And when you talk about mucosil, what is the sort of history that you want to get? They will start off with that, right? Yes. What else? Trauma, accident, motor vehicle accident, right? And then they ask how you manage it. How you manage it? Mucosil. Mucosil is always frontal mucosil, and that is the most problematic.
We have to do an endoscopic, probably muscularization of the mucosil. So we have to, if it's frontal sinus, then we have to go for a draft surgery at 25 draft 3.
Okay, good you bring that up, because examiner cannot put words inside your mouth. But once you start to say that, oh, very good. Tell me about draft 1, 2, 3, right? Tell me draft 1, 2, 3.
Draft 1 is basically just performing ancillary and anterior aneurysmectomy. Draft 2 will be removing the floor of the frontal sinus. 2 can be further divided into 2A and 2B. So 2A is removing the floor of frontal sinus from the middle turbinate to the lamina fabricia, and 2B will be removing the floor of the frontal sinus from the middle turbinate to the septum, and 3 will be combining 2B both sides and also removing the superior part of the septum and the inferior part of the intersinus septum.
So when do you do draft 3?
Draft 3 is when the mucosil is occupying both the frontal sinus.
You know what's the mechanism of mucosil? Why does it happen? It's a block, right? That was the frontal recess drainage area, right? So my question now is, when do you do draft 3?
When is the swelling on the forehead. So you want to release the pressure groups.
And there's a worry about the stricture formation around the area, isn't it? The stricture formation around that is going to promote when you remove that, you decompress that mucocele. Then if there is a stricture fibrosis around that area, you have to do draft 3. If you don't do draft 3, it's going to recur. That's the principle of doing a mucocele, cycle management. Mucocele happen because of blockage. Why is there blockage? Because of the stricture trauma. Previous surgery is causing stricture and fibrosis around the drainage of the frontal recess. Alright? And if that is so big already, it's like blocking, the area of drainage. If you don't do a proper draft 3, the drainage is not going to be remaining open for so long, because it's going to, the natural history of all this healing process is that it's going to cause some, a stricture around the area, because there is a scarring over there. And so most of the time it's a very big mucocele, you have to do draft 3. Then you can make sure that you prevent any recurrence. Okay, good. So draft 1, 2, 3. Actually, to be honest, normally we don't even reach that point. So far, have you come across anybody being asked draft 3? Draft 1, 2, 3? It's not one of our standard question for, because sometimes we think that it's more like a subspecialty kind of approach for us to ask this sort of question. But when you put forward that, I can ask you now, right? You open the opportunity, but make sure you want to give that opportunity to the examiner, make sure you know, right? If not, then you get on struggle. Oh, what is draft 3? Then suddenly you see draft 4. In that situation, it happens. A lot of funny classification comes in. Okay, inverted papilloma, my concern is, it looks so simple, but sometimes what happened during exam is otherwise. One candidate last time did an endoscopic shock case, did an endoscopic examination and found there was a mass there, right? Like a single mass over there. And she made straight away, very happy, make a diagnosis of inverted papilloma, right? And she didn't even look at the other side. And actually, in fact, there was another mass there. And in fact, it was multiple polyps. But sometimes multiple polyps, long-standing, was described as grape-like, right? Translucent. But long-standing, it doesn't happen like that. Long-standing, it becomes very fleshy, very solid. You have seen this many times in the clinic, right? The textbook description as translucent, soft, grape-like, right? Probably the new one. The old one, right? They become quite solid, and it may be mistaken as some benign tumors. Be careful about that. And be careful because you see it's multiple, it's unlikely to be inverted papilloma to be multiple, right? And then see both sides. When you do an endoscopic examination, you're doing running commentary. Sometimes in UM they say please examine first and then give your findings at the end. If examiner asks you to do that, please respect the examiner. But please remember, don't forget to give all those relevant points at the end, right? But I prefer running commentary because you don't miss anything, right? Probably you can ask, I would like to do a running commentary, please, and then you examine from anterior, always anterior, posterior, all the way back to nasopharynx. Don't forget nasopharynx. One external examiner failed one candidate because they didn't examine their nasopharynx, and the concern was because in our area, high rate of nasopharyngeal cancer. You cannot miss doing a proper endoscopic examination towards the back of the nasopharynx, right? Sometimes you just at the front you found there's a mass there, inverted papilloma, then that's it. You don't want to examine the nasopharynx, cannot. You don't examine the nasopharynx, you fail. All right. So please complete your examination. Mention about there's a mass there, then you go towards the back nasopharynx, comment on the nasopharynx properly. Right, and then you come to the opposite side. Then you examine you give a diagnosis, differential diagnosis, management. Alright? So coming back to inverted papilloma. How do you manage inverted papilloma? Siapa pula? Sebelah Khairi. Okey dah. Okay, Dr. Saiful.
So management in the Palima, I would like to get further history regarding his presentation of the complaint, readiness of the case, or the onset.
Okay, we have gone through all that, right? We have gone through that. Now I'm talking to you about management. When I talk to you about management, I ask you about management, it's always about investigation and also treatment.
So in the clinic setting, when I suspect unilateral SMS, I would like to take biopsy first and under topical anesthesia, then send for the HPE. And then at the same time, I would like to request the CT paranasal sinus swab and cutting in axial coronal and sagittal view, both soft tissue and window setting. Then because of the treatment, the mainstay of treatment inverted papilloma is surgery, so I will counsel the patients to regarding the surgery that the choice would be endoscopic middle maxillectomy. But depending on the after I review the CT scan, the extension of the disease, but as a general rule, the treatments can be endoscopic middle maxillectomy.
Okay, if let's say you know the inverted papilloma involve the posterior wall of the emergency sinus, what do you do?
Posterior wall. I still can offer endoscopic sinus surgery. Then during the removal, so I will, if I cannot proper access by at the MMA, so I would like to do another approach to get a proper visualization of the posterior wall to complete my removal of the.
What visualization you do?
By either pre-lechemo or modified Lenker approach.
Okay, good answer. So you know, inverted papilloma is still a benign tumors, isn't it? So let's say I told you, I know that you're going to say endoscopic medium. I just want to test you. Now the tumor is not only the medial wall. You do medial maxillectomy, endoscopic medium maxillectomy when the tumor is involving the medial wall of the maxilla. Most of the time, this is where it is located. But the thing is, sometimes we get extensive tumor that involve the posterior wall of the maxilla. Don't even say maxillectomy. Right? Don't even say maxillectomy because it's not warranted. This is still a benign tumor, no matter whether it's aggressive or not. It's still benign. So we can do a wide medial maxillectomy, right? Then we can even drill part of the posterior wall of the maxilla without doing maxillectomy, right? We can do that. In fact, we don't even need to do, probably if there is a problem with visualization, then you need to do pre-lacrimal approach. But if you do really big, wide, medial maxillectomy, you don't even need that, right? Because you know, when you do wide medial maxillectomy, you have to remove part of the nasolacrimal duct already. You have to reset that, and then you mesothelialize the lacrimal sac. That's what I will do if I do a wide medial maxillectomy. That is how it is being described. Sometimes what we are doing is actually a very limited medial maxillectomy. You don't even cut the nasolacrimal duct. But if there is a massive inverted papilloma, we have to go even more anterior, what we call as extended medial maxillectomy. I'm not sure whether it's extended or not because at the beginning that's how it is being described. But for the sake of you know, proper nomenclature classification, probably we can say it's an extended. You know, we just cut the nasolacrimal duct, we mesothelialize the lacrimal sac. Right? If you have to come to the front to remove the tumor. And when you come to to this side or this area, it's already very anterior already. So you don't even need to go pre-lacrimal. There's no pre-lacrimal because you reset the nasolacrimal duct already. Alright, so bear in mind when we're talking about inverted papilloma, any benign tumor, it is still benign. no matter how aggressive it is still benign. This also applies to JNA. It is still a benign tumor. It's just so that it is a very difficult tumor to manage. And don't be so aggressive that you say that, oh, this needs maxillectomy if it's not warranted. Right? But we have a case before that we did a maxillectomy, isn't it? But there's a different scenario. Then because sometimes the confusion arises because in the case before recurrence, inverted papilloma, then you apply your experience during exam. It must be step by step kind of basis. It cannot be yes, please.
No, I want to confuse a bit. If let's say from the CT scan, the hypostasis at the posterior wall, so is it okay? Let's say I do the white MMA, and at the posterior wall, I should drill or need to remove all the if the origin, the hypostasis at the posterior wall. How should I answer?
When we say we remove, drilling is removed already, right? Drilling, when you drill that, you remove actually. Of course, when you are dealing with the sinonasal area, we cannot remove en bloc. It's always piecemeal. It's not like thyroid mass where we try to remove everything en bloc. The whole lump can come out like that. But in sinonasal area, even let's say you see brain tumors, there's never like brain tumors come out in one block like that. It's always piecemeal. So when we say we remove, drill is part of the removal because we remove the bone, we remove the soft tissue as well. So it's actually done already. We remove already.
The very osteo, from the back there is the cerebrospinal fossa. Should we remove the lining?
My question just now is just to test you, right? But of course, this is depends on case by case basis. How extensive is the tumor? My question to Dr. Saiful just now, it involved the posterior wall. I just want to test him how he answer this sort of question, right? Whether he's going to be like, oh, straight away maxillectomy. Because sometimes when you're under pressure, this is what you're going to answer. It's become like reflect kind, because there's some part of your brain that say, oh, maxillectomy straight away, right? I'll give you a good example. When there is, for example, probably laryngeal case is probably a very good example. You know, there's a patient that has a tumor on the one side of the vocal cord. All right. So now there's a discussion on what is the stage of this tumor. Is it early and late? And the candidate said it was T2. All right. So T2, okay, everybody's happy. And then come to the management. What do you do for this patient? Huh? Okay, so this before exam, this is the sort of answer. Before exam. In exam, the answer came as total laryngectomy. So this is the probably mouth and brain disconnect, right? Your brain is thinking of something else, your mouth says something else. But you see the disconnect there, the T2 and total laryngectomy. This is not really reasonable. There's no rationale. It's early tumors. Why you need a total laryngectomy? So coming back to what I asked Dr. Saiful just now, because he answers endoscopic medial maxillectomy, I'm happy with that. I just want to test him whether he knows or not. The tumor can be extensive. It can goes to the the posterior wall of the maxilla, and in fact, we can remove that posterior vertebral without doing a maxillectomy. Because you have to be open, sacrifice the anterior walls and whatnot to reach that area, and you don't need to do that. When you do drilling, it's actually resection already. Sometimes you thought drilling is just access only. No, when you drill the whole thing. You remove it completely. You can even remove bone without doing a maxillectomy. You can remove the posterior wall of the maxilla. You can remove the whole thing with drilling alone. Alright? But then again, when I say that, you have to assess according to the tumor size. Right? Let's say it's really gone towards infratemporal fossa. How you're going to resect that by doing a posterior wall of maxilla? Drilling cannot. It depends how excessive it is. Just involving a part of the posterior maxilla, then it's worth it to do. But then we not going to ask you this sort of issues lah. Don't worry. Simple things only, but the simple thing you must answer well. Simple thing you cannot answer, you fail. That's it. Right? I'm not going to ask you, oh, the tumor has gone infratemporal fossa. He has gone to the, foramen ovale. What do you want to do? My goodness, I think everybody fail. I'm not going to do that. So why you want to think, oh, why tumor gone beyond? What should I do? So I answer the real. You answer real also, I'm happy already, because that answer real also doesn't come out during exam. That's the problem. Right, that real part also doesn't come up. So we don't go beyond that lah. The tumor go on towards the pterygomaxilla, blah blah blah. You can answer all these things. I'm very happy already actually. Right, and we don't. It's not that complicated, but sometimes I think this exam situation lah. There's a lot of adrenaline and whatnot. You try to figure out probably what examiner wants, right? Sometimes examiner also not some of them not that clear what they want. Also sometimes wonder what they want actually, huh? But my question very clear. Okay. Okay, olfactory neoblastoma, right? Olfactory neoblastoma. When you suspect patient with unilateral nasal block, unilateral epistaxis, right? You must think about olfactory neoblastoma. And the one key factor is smell. Right? One key factor is smell. You always ask, smell whether it's lost or still intact. And the clue is if it lost very early, and once tumors, all smell will be lost because complete block. But the key is ask the patient, the smell, is it lost early on or later on? Right? That gives a clue. And this is sort of smart kind of answer. You can tell the examiners they're going to be very happy with that. There's a clue there, right? Whether it's early or late. Sometimes you come across patient with tumors, even inverted papilloma, it's very massive. Smell will be gone, isn't it? Because it's blocked. There's no airway going through that area. It's blocked. There's no airway smell going to come in and stimulate the nerve fibers there, olfactory nerve. So smell definitely going to be lost. But the key is olfactory neuroblastoma very early is lost because the nerve is already damaged there at the beginning. Alright? Okay. So if patient has olfactory neuroblastoma, what are you going to do? Dr. Saranji?
In patient with olfactory neuroblastoma, there's generally surgical can be. There's few types of treatment. First is surgical. Surgical usually is given to the patient who are actually fit for surgical, and then non-extensive tumor, and radiotherapy is another option, can be given for patients who are surgically who are not fit, elderly, and then unable to go under anesthetic risk.
Sorry, what's that?
Anesthetic risk.
So you want to do under local?
No, radiotherapy.
Oh, radiotherapy. I am asking you that question because we have a discussion about the Raj probably knows very well. First, whether it's under GE or under local. There was a discussion on that last time, isn't it? Okay, but let's not go into that. So, radiotherapy, right, as an option. Okay. So what's the difference between radiotherapy and surgery?
The difference between radiography and surgery is in surgical we can actually get a histopathological confirmation. If we can remove, we can get the actual confirmation of the disease itself.
No, hang on. When you do radiotherapy, how do you know there's a neoblastoma? You don't get a biopsy first?
We'll get the biopsy under LA before.
So now you're saying what? If you do surgery, you can get a biopsy. If you do radiotherapy, you cannot get a biopsy, is it? Okay. Good. Don't say this sort of answer during exam. It makes you very unsmart, I would say. Right? Because that's not how the difference is. Before you start on anything, you must get a tissue biopsy. There's no question about it. Radiotherapy also, you must get a tissue biopsy. If you do a tissue biopsy, you can't do anything. It's a ethical practice, right? before you start on anything, radiotherapy, chemotherapy, surgery and whatnot, tissue biopsy must be definitive. Full stop. No question. But you actually should be talking about organ preservation. There's always the key issue between surgery and non-surgical methods. Whether it's the maxilla, the nose, the head and neck, larynx, is organ preservation versus non-organ preservation. Alright? And this is where I'm going to ask you about radiotherapy side effects. Radiotherapy side effects. You must, this is the thing about exam. Sometimes we hardly discuss on radiotherapy, chemotherapy, right? But during exam, this is the sort of thing that probably we can ask you. Side effects of radiotherapy. Alright? So, please read up a little bit about this. I'm sure probably some of you might know already that radiotherapy is some of the side effects and whatnot, but I don't want you to be caught off guard. Sometimes when you're caught off guard, you don't think that radiotherapy is important, especially the side effects, right? Then you cannot answer very well, and then you get stuck, right? Because you mentioned radiotherapy to me. I'm not putting word inside your mouth. You are saying it, and then I expect you to know about radiotherapy as well. I'm actually giving a scenario what the examiner going to ask you. This is the sort of situation where you are going to come across all sort of questions, open discussion where we're going to ask you question. When you start to say something, I ask you. When you start to say something, I ask you. That sort of scenarios, alright? So far so good, okay? So far so good, okay? Yes.
For olfactory neuroblastoma.
Okay, you're not happy yet with olfactory.
I have a cross question.
Yes.
How do you manage?
Okay.
So after establishing by taking a tissue biopsy and also a CT paralysis, I guess, and we looking at the extension and classify according to cardiac staging, and then we divide into either endoscopic or open approach according to the stages. Is that how it works?
Actually, I've been very liberal just now. If actually during exam, Viva, probably I've been more focused. Now I'm just being very liberal, very open, and not really being really targeted towards the proper discussion about olfactory neuroblastoma. I just want to know how you answer, and then I want to test you. If I ask you in a different way, can you answer that question or not? Because that is the scenario during exam. Because sometimes you cannot predict what the examiner want to ask you, and then when you say something, the examiner will counter back. You know, when you say something, then say like you're in a debate, right? You give some sort of answer, then examiner come back to you, then you can answer. Just for example, just now Tamara mentioned about draft 3. I never asked you about draft, but then she asked about draft, then I say, okay, tell me, draft 1, draft 2, draft 3. Why you want to do draft 3? Then I expect you to answer because you mentioned draft, right? I never asked you what is Tamara, tell me about draft procedure. I never asked her that, but she offered draft, right? Probably I'm expecting that because I'm asking about frontal mucosal, right? Even though I actually didn't say in a proper context that I want to, her to answer about draft, but once you talk about frontal mucosal, definitely you have to answer draft, isn't it? So you know that the situation that as you know sometimes can ask you on some sort of question that you may not expect. And when you talk about frontal mucosal, you must know about draft. You must give that sort of answers. Okay, so olfactory neuroblastoma, actually if I ask you management, right, I give you a probably I give you a Viva sort of endoscopy pictures, and then I put a mass that's superior, right? You must describe. The Viva question always describe first, right? Describe first whether it's you know, in the nose, in the larynx. Describe, give your differential diagnosis. It's always like that, right? Give your differential diagnosis, right? And then okay, then probably they will say, oh, you mentioned about olfactory neuroblastoma. Tell me how you go about managing olfactory neuroblastoma. Okay, so when that sort of question, then you have to discuss regarding imaging, and you have to discuss about is tissue biopsy. When it comes to tumors, benign, malignant, two things are important. What? Imaging biopsy. Imaging tissue biopsy. It's always this two things. You can add on all those. I know both men and women that like cooking nowadays. You know, all the rempah ratus apa semua. The blood taking, you can talk about if granulomatous disease, what si angka, all those you can put in. But if without these two ingredients, you cannot survive. These two ingredients are the imaging biopsy. That's it. Alright. All the other things are additional bonus. Yes, please.
I just want to ask, imaging versus biopsy in math, you see superior and nasal cavity. So either, can you say that because the math is superior, so
Sorry, what's that?
if the mass in the superior part of the nasal cavity,
The mass
yeah,
and the superior aspect of the nasal cavity. Okay.
so can you say that you're afraid to take a biopsy from the superior part because it's arising from can be arising from the skull base or something? So can you ask for a CT scan instead first
Yes.
before?
Definitely, you know, when we talk about investigation, it's non-invasive to invasive, right? It's always non-invasive to invasive. If you are, you don't feel that secure or you don't feel that you are able to do biopsy under office procedure, you can go under UP, exhibition understanding, then you can take the biopsy, right? And most of the time, that's what we practice here, right? We're not sure or certain what is the mass. We just scan first, right? That scan come back as suggestive of veterinary person. What do you do next? We take biopsy, isn't it? Right? If you, most of the time, we don't do biopsy because we're scared of bleeding, right? It's not that we think that there's something, you know, that cannot be taken, you cannot take biopsy there. And the other thing is you don't want to take biopsy if you suspect there is encephalocele, meningocele, true or not? But then, when you suspect this sort of, situation, when the patient comes with bleeding, I told you there's history just now, bleeding, smell loss and whatnot. Do you think this is going to happen, patient has encephalocele? No, right? So that's why when I asked him just now, I'm not being very open about the diagnosis. I asked him, how do you manage, ophthalmoblastoma, right? So let's say you have a unilateral nasal mass coming from the superior aspect of the nose. Okay, give me your differential diagnosis. Then you say frontal encephalocele, meningocele, ophthalmoblastoma, right? So then you're going to tell me investigation. How do you investigate this case? You're going to tell me CT scan and MRI. Definitely MRI is going to be there because if you go into the brain and whatnot, you want to make sure how whether the brain is involved or not, or what the intracranial structures is involved or not. There's always some discussion between CT scan versus MRI. All right, trust me on this. Trust me, when you go to the skull base, there will always be a discussion on CT scan, MRI. Sometimes when you say CT scan, I want to do CT scan paranasal sinus. Okay, good. What else? So you know that what else means they want to use to say MRI. Okay. So during exam, they're gonna say what else? MRI. Okay. That's the trick, okay. So you know that is the sort of scenario. We're not going to trick you. I'm not going to trick you. Let's say that okay, unilateral, there's a mass coming from there. Then I want you to do biopsy without confirming the diagnosis. You have to confirm the diagnosis first by all this investigation, right? That's why when I asked him just now, I say, how do you manage? I don't say that this is unilateral, there's a mass. You don't want to do biopsy first or not? Right? Because he answered me by saying that I want to do surgery, I want to do radiotherapy, and I asked him what's the difference. And I said, with doing surgery, I can get the tissue biopsy. And then I said, hey, what happened? When you do radiotherapy, you don't get biopsy, is it? So that's very dangerous when you say that sort of circular answer will get you into trouble. Because when you commit to doing management of the patient, that means diagnosis is established already. You cannot do anything without establishing the diagnosis. Alright? So make sure of that. Okay? Apa? Tambah sikit.
Okay, no problem.
Anything you want to add on this?
Cuma kalau UKM, dia nak exam mana? UKM. Kalau UKM saya tahu ada HHT ada juga. Knowledge is one of the long cases.
Oh yeah. Yeah.
Short case saya tak ingat, tapi dalam case tu ada that patient.
Okay, I think Dr. Yes, you. How do you diagnose SST?
There will be on endoscopic examination. There will be multiple dilated vessels.
Multiple telangiectasias in the nose. Okay.
And on further history, taking, we ask the patient if he or she is having any family history of anyone in the family having similar issues, and if the patient has any other systemic complications like persistent headache suggestive of aneurysm, or she's having bleeding from polyps, they present with lower GI bleed.
Anything else?
Yeah.
Yes. You mentioned that. You mentioned. Most of the time when we talking about hereditary telangiectasia, patient has epistaxis, right? The main presenting symptom is epistaxis. And you know what's the characteristic of the patient? Characteristic of patient with SHT? Just like you see patient DNA, adolescent, boy, what's the characteristic? Typical. No. Patient characteristic. Huh? No, patient characteristic, gender, age. One is male, one is female. Female? Female age? Drama, is it? You're thinking about postmenopausal nowadays, huh? Wow, that's too advanced. Normally, hereditary telangiectasia is 40 years and above, right? Female. This is typical. You can read your textbook. This is typical. I know why. Because my patient is this kind of patient. I came across this hereditary telangiectasia actually came from Kota Baru, Takari probably. You miss it. You were in Kota Baru. She went to Kota Baru. It was not diagnosed. She came from Kota Baru. She told me it was managed there. But yeah, because if you don't really think about this sort of condition, you're going to miss it. And she gave this typical history that Tamari mentioned. She has persistent epistaxis both sides. I examined her with endoscope. I saw a lot of this telangiectasia around the nose, on the floor, on the septum, everywhere. And in fact, you put in the scope also bleeding. Is that kind of very easy bleeding? She has history. The sisters also has history of epistaxis. Family history is important. And also she has some kind of ultrasound examination of the liver. We showed some arteriovenous malformation, right? And also when you look at the tongue, there is also this reddish discoloration which actually suggests telangiectasia on the tongue as well. So there are 4 criteria actually. I can't remember offhand. What's the criteria? Yeah, maybe something like that. But there are 4 diagnostic criteria. You need only 2 out of 4. 2 out of 4 to really bleed epistaxis, right? It can be AV malformation of the brain, lungs, or liver, or anywhere in the body, or it can be telangiectasia, not in the sinusoidea, but telangiectasia in the other system. Because telangiectasia bleeding, epistaxis, telangiectasia in the nose, one, and then you need telangiectasia changes in the other system. So that means in the oral cavity. So then 2 out of 4 is positive, together with the family history. 2 out of 4 is positive for hereditary telangiectasia. How do you treat?
Laser and the spot.
Conservative and also surgery. For conservative, you can give estrogens and anti-androgen medication. And for surgery, you do septodermoplasty or a young operation.
Yes, what's young?
one side of the nostrils. Usually is done for patients with gastric rhinitis.
So you suture the mucosa together, so in the hope that this stigmatization disappear, right?
Yeah.
Yeah. So that's what you we do for for this stigmatization. So as always, medical treatment and surgical treatment. Or we can also do a symptomatic treatment. We just coagulate this stigmatization spot. We can do it as a cryotherapy or with electrotherapy, right? With detamine. We go to the stigmatization spot, then we just detamize around the area. We can do that as well. It's just direct symptomatic treatment, and that's most of the time that works for patient, because young procedure is, I haven't seen anybody do a young procedure. Probably that involve massive bleeding, life-threatening, that you still really require to do a young procedure. But at least during exam you must answer that, right? So don't forget about this HST. You might come across. Okay, actually I forget to mention to you why I put up this. I want to tell you about how you must know how to read CT scan, right? For rhinology as well as pathology, if there is long case, even during viva, you're going to come across a CT scan. Let's say for example CRS. Okay, now the CT scan probably going to be given to you, right? Then you're going most of the time you can scroll, right? It's not like a fixed there. It's like a moving on the computer. You can scroll. When you scroll, right? Probably you're going to start from the brain. You must say, we always practice this, but during exam, please be aware that there is because in that situation, you need some time to calm down. So then you just say CT scan of this patient taken at this date. What is that kind of CT scan that's been done, plain, contrast, alright? And then always compare both sides. When you scroll down towards this sinonasal area, compare both sides. Compare both sides, see whether there is any abnormal area. Normally there will be some changes there, right, at one side. Then you see if there is unilateral changes, please mention that, right? Especially if it's a tumor, right? If it's a bilateral, probably it's CRS. Mention about the opacity, right? Mention about each sinuses, maxilla, ethmoids, frontal, sphenoid, and then when you make a diagnosis, you can see these are pansinusitis. We are talking about changes on CT scan or imaging. It's always about opacity. It's always about mucosal thickening. It's always about any obstruction along the drainage area. For example, osteometal complex is blocked. OIC, OMC is blocked. So that sounds very intelligent, right? Because you know this is important, right? Because most of the time when you see CT scan, this is what I will always look for. And then don't forget about those closed. We always discuss closed, right? But during exam, closed doesn't come up. During exam, I hardly hear people say about closed, alright? Because what happened during exam is, as you know, we ask you, okay, what else? What else? Because they want you to tell about lamina papyracea. Closed is part of it is lamina papyracea, right? And then Kiros, right? The cuneiform plate, Kiros. Always mention this because you browse through or scroll down the CT scan. When you're going for surgery for this kind of patient, you want to know about Kiros, right? But this sort of answer doesn't come up until and unless we keep on asking you question. And then when we keep on dragging like that, you are like under pressure already. I know that because when I say, okay, what else? Then you say, oh, what else? What else? But actually, we just want to know what is, you want whether you know about Kiros or not. And in fact, when I said to you, whenever you see the CT scan, you can guess straight away what is the Kiros. Satu.
Type 2.
Type 2, right? Type 2 is the most common. So you can, even without measuring, you can see or straight away it's type 2 keros. Alright, type 2 keros. But of course, you know, that is just an guess estimate. But if you want to really confirm that, you have to really measure accordingly. But from the straight away scan, you can see straight away that is keros type 2. The most common. Hardly we have type 3. We don't have type 3 in Malaysia. And also in Indonesia, at least in our sample. And also probably in KL also, I saw publication there, they said there's no keros type 3. In Indonesia also no keros type 3. Right, so safe to say that type 2 is the most common. So keros also, you didn't mention, you should mention keros type whatever blah blah blah. At least mention keros lah. You don't see the type. At least mention. I want to see the keros precipitation and whatnot. The lamina papyracea, and then the the anatomical variant, right? Not only on the cell, the anatomical variant, right? So that means on the cells, hilar cell, whether there is any aberrant vessels or not, especially low-hanging intraemoral artery, right? Because if you are going towards a frontal recess, you're probably going to come across this sort of aberration. What else? Yes, and when you go towards the sphenoid, sometimes there is this, the optic nerve, which is actually dehiscent. Right, so what happened is you are clearing away or even dehiscent around the internal carotid artery. So you put in a suction there, right? You put in a suction there, and then you suck. And what happened is rupture, because there is dehiscent. You're not careful. So from the CT scan, you can talk about all this anatomical variation. So you can see a lot of things that you can talk about the CT scan. I'm just giving you an idea here, but during exam, you just tell me about the changes, I'm happy already. We don't even talk about anatomical variation. You're going to get lost around that area. You tell me CT scan of this gentleman or this lady taken from this date. What are the CT scan? What is the CT scan? Type, plain, contrast, right? Bone, soft tissue. Then you describe to me the changes. Right, and this is my diagnosis. Right? Trust me, you're going to get a CT scan. Make sure you can read the CT scan, and this applies also to pathology, because I come across a lot of time you have a cholecystoma case, you cannot read a CT scan. Because when you read a CT scan, sometimes you mention about internal carotid artery, and then they ask you, where is the internal carotid artery? You cannot pinpoint where is internal carotid artery. You are saying internal carotid artery, but when they ask you where is internal carotid, you cannot pinpoint. That means you are just textbook description. You don't really see it properly. Alright. So CT scan you must read. You must be able to read CT scan for both rhinology. That applies to all, but especially for I see most of the time I see candidate cannot read a CT scan of the paranasal sinus, cannot read CT scan of the temporal lobe. And this most of the time, this is what the examiners commented on. All right. Okay. Any questions? Okay, let me explain further about this lymphoma of the orbit. You may want to ask me, if you get this kind of case, right, during exam, there's no changes in the nose, right? There's no changes. What should you do? Okay, good. But before you go for that, please come up with several diagnoses. please come up with several possible diagnoses. You get this patient have epistaxis, right? Epistaxis, but you don't see much changes in the nose. And you know lymphoma is quite common in the nose as well, right or not? You must think about all these possible scenario. You come up with several possible diagnoses, then you go for investigation. You go for investigation because I think in this sort of scenario, probably diagnosis must come after the investigation. If there's no changes in the nose, you cannot offer some certain diagnosis because there's no changes at all. And this sort of scenario, you have to offer some possible diagnosis. So if it's unilateral, you must think about all the possible scenarios. What are the possible scenarios for unilateral bleeding, unilateral epistaxis in the sinonasal area?
Probably draft plexus.
Yes.
Hypertensive bleed.
But you know during exam they won't give you ultra plexus. Because ultra plexus, how can you discuss during long case? This is the long case scenario. But there's no changes. There's no changes.
Submucosal NPC. Submucosal NPC.
Yes, good. Possible. When you get this very, very uncommon scenario, we don't really penalize you if you cannot come up with the proper diagnosis. We don't penalize you for that, right? What we want to see is whether you can discuss this sort of cases or not, right? So along the way, you must think this is probably, I think this patient has some problem in their orbit as well, right? In the long case, you should pick up on this sort of, clue to lead you towards a certain diagnosis. And we know that lymphoma, you know that can very common in the orbit, whether you realize it or not. Lymphoma in the orbit is one of the commonest tumor, right? And don't forget in the nose as well, right? Part of the division diagnosis, and this applies to children as well. Part of the diagnosis for sinonasal tumors in the nose is actually lymphoma. So think about that. Yes.
Patient is the presentation here.
Epistaxis.
Epistaxis.
Epistaxis. I think there is. I just can't I forget what is the eye symptoms like. Because it was some discussion about that. Some of us not very happy. Yeah, because there's hardly any findings actually in the nose. They are saying that there's some reddish discoloration over the median metal area. But when we do scope, in that situation, it's very hard to see any reddish discoloration. Even blackish discoloration, you cannot describe. Reddish discoloration is for sure you cannot describe.
Is this the patient yang kat posterior septum ada mass ke?
No, there's no mess at all. There's no mess. There's no mess at all.
Ingatkan yang ada kes yang
No.
RT ke satu dapat.
Actually, the
Posterior septum ada mass.
no, I think the diagnosis was changed only on CT scan. When they did a CT scan, there was a mass there.
Tapi dia ada B-symptom lah besides that. Dia ada proptosis.
Maybe proptosis. But even that is also probably not that apparent. It's not that obvious. That's why I said, if you are very lucky, hopefully you're not that lucky. We had a discussion about that. A lot of people not happy, but then I think we give that kind of leniency. Leniency means you don't get the true diagnosis, we're not going to penalize. So that's why I'm actually saying, please come up with several possible diagnoses. I don't want you to panic because once you panic, it's gone already, gone case already. Don't panic. For sure, you don't get the right diagnosis, we're not going to penalize you. But you must be able to give some possible division diagnosis and then discuss it like when you discuss any tumors. Discuss it like when you trying to establish or investigate any tumors. When you come across benign tumors, how do you assess patient? Malignancies, how do you assess the patient? You should apply the same principle to this sort of scenarios. Don't panic and then think about all those, you know, crazy things, crazy imagination and whatnot, that gets you into trouble, right? Be composed, be calm, be cool, and then applies all those. I always tell you, right? Only two things when you're dealing with tumors. Two things only. You must talk about CT scan, MRI imaging. You must talk about getting the tissue biopsy, right? But in the certain cases like this, you think about granulamatous tissues and whatnot. You must talk about all those blood investigation, some tumor markers and whatnot, right? And then this sounds like very intelligent kind of answers already. And most of the time, when you talk about this, engineers are quite happy already. Don't get stuck. But as compared to this one, you see, this is different scenarios, right? This is different scenarios. When you get this, you get stuck along. I give you a good example of FAST. During Viva, I wish this example. Probably a lot of you probably knew this story already, but bear with me. Old people, they like to talk, repeated stuff. You know? So steps: asunectomy, correct? Middle metal antrostomy, and then hemodectomy, splenodectomy or splenodotomy, and then frontal sinusotomy, correct?
Yes.
During exam, it doesn't become like that. During exam, the first step will become MMA. Surprise, huh? Surprise. Surprisingly, that's happened. Then we go, oh, is it true? MMA? Yes, MMA. Keep on insisting MMA. Okay, go ahead. MMA, hemodectomy, and then splenodotomy, and then frontal sinusotomy. So you see, this sort of step became haywire, and it's very straightforward, isn't it? It's nothing complicated and just a simple step. And the idea is, when you mention this step, the examiner will ask you what instrument you use during asunectomy. Then you talk about using backbiter, right? To open up to remove the asunectomy, to perform an asunectomy. Is it backbiter asunectomy? Correct, right?
Yes.
Right? Sometimes I get excited, I mentioned the wrong thing. Then the medial metal antrostomy, right? What instrument you're going to use, right? And then when you do hemodectomy, what instrument you're going to use? That's the whole idea. Then when you get stuck, even the first step also wrong, what you're going to foresee going to happen? You know that candidate failed. That candidate fail. I'm not the one who failed that candidate. The examiner. It's always the examiner who fail, right? I always pass. But when we discuss this, especially from KKM, KKM now the examiner is quite tough, you know, because I think probably you're going to go to KKM, so they're not happy with you if you don't answer properly, because they said you cannot manage this sort of cases, which is very common procedure, very common cases. Then how you going to be practicing alone? How can we let them to practice alone? That's the argument, and that's why sometimes you fail. I mean, you cannot answer properly. You cannot give a proper diagnosis for this. We still can give some allowance there. But when you talk about CRS, you cannot answer properly, you fail. Right? And I come across sometimes, I feel that you are, get this sort of cases, you should be like talking freely, very smoothly, you won't have any, problem at all. But somehow or other, some of you have problem, you get stuck, you have problem. And then already when you get stuck, with this case, you are in trouble water already. You get stuck with this case, we still can consider. This case, then you are actually in dangerous territory. I hope you understand that. I don't want to scare you and whatnot, but just be aware, all these common cases, you must know very well. How you manage. Sometimes we take it for granted, like for example the instrument just now, we take it for granted, a simple instrument. But these simple things that we ask you, you cannot answer, how do you explain? Right? We ask you about steps in FAST, you cannot answer, how do we explain? The explanation is because you hardly do the proper procedure. You don't go to the OT to see how people do. You don't do yourself. Because if you do yourself, how can you answer MMA first? Because you know already first, you always start off with the anatomy. So how do you answer MMA? Right? Probably slip of the tongue. If it's slip of the tongue, we can, okay, is that the first step? You know already, we give you some second, you know, second chance already, right? We give you a second chance. Oh, is that the first step? Oh yes. So MMA, you know. Sometimes you will think that as you know want to treat. Sometimes as you know just want to actually give you a chance, right? But it's because you insist on that kind of answers, then we cannot do anything else, and then you'll be penalized, right? Simple things. Sometimes you know, I think it's just not worth it to feel simple things, right? You feel difficult things sometimes. You go back, you feel proudly, you can say, oh, I cannot answer a very complicated question, you know. But then you feel simple things, like, how can you say? You know, I feel very simple things. I'm just trying to joke around these simple things kind of thing issue, but actually, you know, the examiners are unhappy when that happens. So then you have to put in their shoes, you know, in their shoes, how they perceive you, because they don't know you. I know you. I know that sometimes in that you have been performing very well in the hospital and whatnot. We know you, but they don't know you. Right? Any other questions? So you have gone through a lot, right? This morning, Prof. Ramiza, Dr. Asni, Dr. Rosli also okay.
Yeah.
So what did he talk about?
The validation and conduct how we should answer the common question that being asked in the exam, what mistake usually the candidate done, and then they give the advice also lah. And then
You know, the thing is, during exam, what I see is something like this. We always practice, right? We always practice. I always tell you, okay, this is what you should do and what you shouldn't do. For example, when you do an rigid endoscopic examination, we always tell you during exam, don't go into the middle of the patient, right? Just go at the side. But during exam, you panic, right? You always panic. So this is what happened during exam. You must always, like when you're driving a car, right? It's becoming automatic. Because if let's say you have been practicing all this while like that, you know, then during exam you want to change your style. It does not happen. It does not happen during exam. During exam, you panic, you go back to your original self. Right? So probably that is what happens. So I hope, please remain calm and composed. Right? So don't panic. Because I don't know, in that situation, everybody probably panic, but panic a little. Right? Think what is in one. You're not clear, please ask again. Alright? You're not clear what is in wants you to do, please ask again and clarify. Most of the time, examiner will be quite simple actually. Please examine the nose. Please examine the left nose. Please examine the face of the patient. Alright? That means probably there's some symmetricality issues and whatnot. Please examine the face of the nose. Then you describe. The step is always describe first. See properly. Become composed. Right? Then all the steps completed. First the organ, and then the additional related stuff, additional related structures. For example, if the nose, then probably you need to want to check the ears as well, because if patient has essential dysfunction, there might be some changes of the arterial membrane over there. If there is a mass in the nasopharynx, we want to check on the oral cavity as well, in case the mass is coming down into the oropharynx. So that's all the related or direct relation of the structures to that particular system, and also then you go in the to the other distant organ, for example the neck, not so distant, but probably whether it's related or not questionable, right? But still you need to check, right? And then you must mention, right? But short case, for example, you won't have time, but you must mention, okay? Then you come with the diagnosis. What is your diagnosis? Then offer a differential diagnosis. When we have, for example, a tumor in the sinonasal tumor. So when we talk about differential diagnosis, most of the time we talk about sinonasal squamous cell carcinoma, right? You talk about histopathology. You can talk about histopathology, but differential diagnosis is not only histopathology. Differential diagnosis means other tumors. You talk about sinonasal cancer, then you talk about squamous cell carcinoma, BCC, you talk about leukoplakioma. These all histopathology. But when you talk about differential diagnosis, it's not histopathology. Differential diagnosis is squamous cell carcinoma, olfactory neuroblastoma, lymphoma, plasmacytoma. That's differential diagnosis. And this is what sort of differential diagnosis that we always get from candidate. Not only to rhinology, but also to head and neck, parietic, even thyroid. Parietic, when we have a mass there, you talk about what pleomorphic, what is tumors, adenocystic, right? Adenocystic, adeno-CA, blah blah blah. But actually, what we want is actually parietic tumors and other differential diagnosis besides parietic. That means sometimes we have a mass here. It is keratic body tumor over here. It could be parietic tumor. It could also be a keratic body tumor. And in fact, actually it was a keratic body tumor. And candidate say parietic tumor, pleomorphic, adenocystic, or all the blah blah. See, differential diagnosis, but histopathology, right? Think about the possible differential diagnosis. Not only histopathology is good, at least you are saying something, but don't forget about all these possible differential diagnosis as well. What else Dr. Rosli mentioned to you?
Some scenarios also lah, some scenarios, and then we did some short biography, and then explain the appropriate way, what is the clue that is really examinative that we need to pay attention on.
No, what is the difficulty that you think that you might have during exam?
Understanding what examiner.
That's one thing. That's one thing. But like I said, if let's say as a video you're discussing investigation, imaging, CT scan, then if they say what else, then probably MRI. You know already. If you're in that particular spot, you must think about what is the investigation that you're talking about. But I know there's some examiners also sometimes they ask you. I also don't understand what they want.
Don't worry, we have at least
Yeah.
3 examiner and they will average the mark. So if one examiner has like, candidate kena keluar juga keyword ni, you don't worry because bukan bakal dia saja, orang lain punya juga.
But the main thing is you must be able to talk. Don't sit quietly and blah blah, just quiet then sweating and whatnot. Just talk. Just mention whatever that you can think about. Because you stop, you cannot speak properly. Then as the main thing that you don't know, right? So the main thing is don't stop, don't panic, just become composed. Just talk whatever you think that the incident wants. Don't just sit quietly. You don't want to, because you say, oh, this I don't know what you want to know from me. Then I just sit, I don't want to say anything. Just talk. CT scan. You at that time probably can't remember about MRI. Then you go on to the next one. Sorry sir, I can't remember what else. Probably I can remember later on. And just go on. You know what else can you say, right? What else can you say? At least you're talking, right? The main thing is you must talk.
Is it wrong to say, can I pass this as I? Because you want to go on with the next.
Yeah, I forget a little bit. But what else can you talk about? Because I already start. At least you make fun of yourself. It's still okay, right? Instead of you sit quietly and then you don't say anything. At least you talk like that. Then probably along the way you might touch, or you might just accidentally mention, oh, they say, okay, that's what I want. Then who knows, right? Yes.
One question to clarify regarding the medical treatments of the CRS business of poly, because this morning we have a session with Mr. Rosli. So what we have been practice here, the regime of medical therapy for CRS poly, including the intranasal corticosteroid and also plus oral steroid also, and also macrolide. But this morning when we answer like that, the say that they can not practice the oral steroid and also macrolide. Some center only, but mostly they can give only 1 week before the ops. So how this?
What does the guideline say? What does the guideline say?
Include the oral steroids.
You know the guideline says you can use intranasal corticosteroid, you can use systemic corticosteroid, you can use macrolide, either single or in combination, or 2 combination or 3 combination. Right? You can use that combination or that kind of medication in CRS without nasal polyp, in CRS with nasal polyp. You can use that. Guideline says that. So when you say that, nobody can say you are wrong. Nobody. And throughout this, I've been, been an examiner. Nobody has failed because you mentioned macrolides. Nobody has failed that you mentioned, I would like to use systemic corticosteroid and macrolides. Nobody has failed because of that. They fail because they cannot mention it. Right? So you see that's the irony, right? The irony is you fail because you cannot say I must manage this patient by using intranasal corticosteroid. If patient don't respond, I would like to give short course of systemic corticosteroid and also macrolides. Right? What macrolides? Clarithromycin. Right? Nobody has failed because they mentioned this. Why? Because it's in the guidelines. Nobody can say you are wrong. And it is found in Scott Brown. Who dares to say Scott Brown is wrong? Put up your hand. Right? This is from personal opinion, personal practice. You leave it to them, whatever they want to say. But you mention during exam, nobody can fail you, nobody can say that you are wrong. Be confident of that. Be confident. Right? It's just that, when you mention about using systemic corticosteroid, how do we give it? What are the precautions that you must take? You must know about that. If, for example, patient has other systemic illness, you have to be careful. Patient has fatty ulcer, you have to be careful, right? And especially when you give systemic corticosteroid, there must be monitoring of the patient. You give them 2 weeks, follow up 2 weeks, right? Not like us, my clinic 2 weeks, give 2 weeks medication, 3 months follow up. Don't follow my style. But actually, when you give 2 weeks, monitoring 2 weeks, follow up, correct? But I know that there are certain practice where they don't want to use macrolides and whatnot. But you see, whenever you go to any meeting, congress, do you hear people talk about metro lights or not? Of course, of course. So where are you coming from to say that you don't, it doesn't work? Because people have done studies to show that it works. Whether you want to use it or not is a different matter. That you have a certain preference. Sometimes you have a certain tendency or predilection for certain medication. For example, whether you want to use claritine, whether you want to use Zysa, that's up to you lah. But still, some people say this is work and this work, and nobody will say that, oh, you cannot use. It won't happen. Alright? Yeah. But you must make sure that when you say macrolide, you don't use it as an antimicrobial. It's an immunomodulator. So then, if let's say, why you want to use macrolide? Oh, sir, it's immunomodulators. Right? Then they cannot say you are wrong. Right? Don't be scared with all those issues. As long as you follow the guidelines, you are safe. I know the other issue is how many times you give corticosteroid before you go for surgery, isn't it? There is in UKF there is a regime, right? 2 times or 3 times before you go for surgery. I think 2 times, twice, right? Huh? Twice or 3 times? 2 times. But actually, 3 times. No, actually, that's what we do anyway in our clinic, but we don't calculate according to that lah, What is what you do also, right? We give to one steroid, it resolve, right? And then come back again, we give another steroid course, right? Then come back again, that means it's recurrent many times, then we go for surgery. Of course, we don't one time start steroid, then we immediately go for surgery. We don't do that, isn't it? That's what we do anyway, but we don't count like that lah, Masuk dalam checklist. Oh, this patient twice surgery. We don't do that. We according to patient response. And talking about this, is there any guideline that mention twice surgery then you only go? There's no guideline to say that. It's just that that's how they practice. If let's say this patient fails 1 time, patient is back already, I still go for surgery. There's no harm. There's no nobody can say that. Patient, you started on systemic corticosteroid 1 time, cannot go for surgery, contraindication. There's no such thing as contraindication, right? But most of the time, you try your best to give conservative first, optimal rehabilitation. That's the key word. You optimal rehabilitation before we subject the patient to surgery. At least when patient go for surgery, patient develop complication, even though you have done your best and whatnot. Then you say already, because we have tried our best to give medication, it fails. Then we bring patient for surgery. Then we have to take calculated risk. That's what we call as calculated risk. Patient that has complication and whatnot, suddenly we go for operation, even though we have taken proper consideration, precaution, something happened. Right? For example, CSF leak, laminar operation and whatnot, right? Using microdivider without proper precaution, the family. So that happens, right? But because you have done your best to optimize the medication. Right or not? So I think that's probably the reason why people say, oh, two times, 3 times, you must optimize the medication first before we go and subject the patient for surgery. It's not that there is a sort of regime that you must follow every time and only time, that this is the only way to do it, to go about it for patient with CRS. Why are you so quiet? I give you a lead question already, what?
Okay.
This is a lead question, what?
Okay.
Not enough.
Convincing.
Convincing, huh? Not convincing. Convincing. But I still wonder whether they can answer or not. Sorry, good.
No problem with the rising COVID cases.
Rising what?
COVID cases.
Or you wonder whether it's going to be postponed?
No, not postponed. Is there will be any change in
we have to update you later on. There was a discussion in the conjoint board. Even like for example, it's not possible or not what you should be using, like PPE and how you're going to do voice test. Because when you have that, very difficult, isn't it? there was a discussion. There was a discussion on that. I think you have to get the information later on. It's still under discussion. There's a worry about the exam going to be postponed later on, depending on the cases now. It keep on rising, right?
Is it possible to postpone again, Prof?
I don't know. There was I just mentioned to you there was a discussion on that, and there was some examiners that expressed the worry that it's going to be postponed again. But I don't foresee that from happening now, because now what is happening is the Sabahan case only, right, because of the election, and since they already managed to contain that with all the screening and whatnot. I don't see that exam going to be cancelled or postponed. But we have to see what happened. That's from Sabah, right? From returning from Sabah. And now, nowadays what they will do is targeted. If let's say that particular place or location has high number, they just put in the the safety measures lockdown. So then. Nowadays they can identify that location, that site, and then they can just put under lockdown. That could be contained. Last time, because they don't know what happened, that 15,000 religious attendees, they don't know where they have gone. So then they have to put the nation under lockdown to identify and whatnot. Before then, after that they loosen the lockdown. So now, I think even though there are quite a number of cases, probably less risk of that sort of thing happening again. I think a lot of people won't survive in another national lockdown. I think a lot of people will die. I can tell you for sure, because have you gone to Ion? Paparish is closed, You know Paparish, Kopitiam? Closed. One of my favorite restaurants. You see a lot of shops being closed already in Ion. So I don't think that we're going to survive another lockdown, nationwide lockdown. But just hang on the updates. But so far so good. There's no news about being cancelled and whatnot. It's just the standard precaution. I guess patient probably have to be screened for COVID-19 before, because there'll be a lot of people there doing all sort of invasive procedures. I think so. I think by right that should be done. I don't know whether examiners or candidate has to be screened. But hopefully your patient has to be screened.
The patient is willing to come and undergo the test, being examined.
That's the challenge.
So many.
That's the challenge. But hopefully some incentive will come. 100 ringgit. 200 ringgit. And free food. Sorry? 500. But when they do exam, the test there, it's going to be free, of course. Right? So Sakinah, you like to add more some? Autology is another killer.
Zone killer.
Yeah. I think I've observed so far autology and laryngology. make sure you score very well, rhinology and also head and neck. Especially short case. Okay guys, good luck. My clinic always welcome you. I always welcome you. You want to practice, I want to always most welcome to join my clinic. Oh my goodness. Thank you very much. Ada hadiah juga. Pada kembali But you don't have to actually. You don't have to.
Supaya ni waktu yang saya nampak yang ni
Ini berkat.
Dah stop.